A very nice welcome to you all for this session where we are talking about the Nordic Health 2030 movement and also the European Health Union and the effect of our future health initiatives. As anyone that lived through 2020 or 2021 will know, health has a tendency to affect across borders and also then create both political and societal ripples. And today we're talking not just about the ripples for an individual country, i.e. Sweden, but also the cross-border implications of both the pandemic and the political challenges that it presents and also gives. With me today, I have three speakers from, Europe, Sweden, the Nordics, Tamara Hervey, Marianne Larsson, and Bogi Eliasen. And we'll be discussing both the elements and implications of the European Health Union, the implications and elements of the future health in Sweden, and also about how we proceed and progress perhaps towards a new social contract for health in, the Nordics, but in Europe perhaps also. Tammy, please, the European Health Union. Could you please give us a bit more info about what is actually the idea behind that? And I'll allow you to get the full floor, and Marianne and I will shut off our cameras and give us a few inside stories. Why, how, when, and can it actually be done?
Good morning, Lars. Thank you very much. And thank you for the kind invitation to participate in this webinar today. I'm very, very grateful to you. I'm Tamara Hervey. I'm a professor of law at the City University in London. And I've been studying European Union health law for several decades. I should say often from a quite skeptical perspective. The European Union's contributions to health have not been stellar in my view over those last decades. But nonetheless, the European Union is a potential site for positive health law and policy. And that, in one sentence, is the opportunity that sits within the concept of a European Health Union. Now, what we have at the moment is a set of essentially missed opportunities in terms of the European Union institutional space and the possibility for using that institutional space for the health of European citizens and others who live in the European Union, and indeed in the places which the European Union trades with, which is the rest of the world. So a European Health Union would be not only important internally for the European Union, it would also be important globally, potentially. And the European Union has an opportunity to lead in terms of health law and policy. And we've seen some examples of that recently. If we look at things in a positive light, for example, the European Union's leadership of the global vaccination campaigns fairly early in the pandemic is an example of the potential for the European Union to lead in health. Now, the problem that we have, and the reason that we need to move towards a European Health Union, has to do with the structural arrangements for health policy and law in the European Union as it currently stands. And those come from the history of the European Union. So what we have structurally in the European Union is we have a process of integration, which includes economic integration and includes bringing markets together, but also includes an aim for integration in other policy areas. And the one that got going at the very beginning of the European integration story is actually in agriculture. So the European Union has never just been about markets, it's also always been about having common shared policies. The thing that we have at the moment, the phenomenon that we have at the moment, is that when the European Union undertakes most of its health policy actions, it undertakes those health policy actions by shoehorning them into other policy areas, other competencies or powers. That's not true for all of the European Union's health law and policy making. So, for example, the regulation of medicines, including vaccines, the regulation of substances of human origin, those have a particular place in the European Union structures, and they are relatively well catered for. But many, many other health aspects, regulation of harmful products being a candidate among them, the European Union's regulatory activities have had to be fitted into other policy areas. And the most obvious policy area to try to fit those in is the European Union's internal market competences. Now, the consequence of that structure is that the people who are around the table when the policy is being discussed, formed, made, and adopted do not necessarily include people with health policy expertise. They include people with expertise in the policy area, the internal market, let's say, where the policy is being made. And it also means that the legal rules have to be made in such a way that they are compliant with the competence rules of the European Union. And so those two deficiencies in the European Union's current structure, who is around the table and what does the overarching organizing features of the rules need to be, those are holding the European Union back in terms of developing really strong health policies that will actually help the health of European populations and indeed populations elsewhere in the world with the EU's trade partners. So this is why we need a European Health Union. We need the European Union to have more competence in the health field and more explicit competence in the health field, so that when the European Union pursues health policy making or health regulatory activities, those regulatory activities have health front and center, and the people who are involved in deciding the specifics of the regulation are people with health competence, with health expertise, who are in the health ministries or who have experience in health policy. So what that means is that, in fact, although giving the European Union more health competence seems like a dangerous thing to do for people in the health policy community, in fact, ironically, giving the European, or counterintuitively, giving the European Union more health competence will actually mean that health is present in the relevant policy making places. And I think that's my 10 minutes up. So I'm very happy to take further points and questions in the Q&A.
Well, I suppose that the key element here is sort of in my discussion, or sorry, my question initially, can it be done? Your response would sort of be, well, they're doing it already. So why not do it right, or do it perhaps in a democratic way? I mean, the future focus, if we don't do this, what would you describe sort of, I mean, if they're doing it already, and I'm not being provocative, I think, but if they're doing it already, why bother? I mean, aside from what you said already, but will it have any downsides per se? I mean, people are nice and so on. What's the problem of having, if good people are deciding health policies already, surely, what's the problem?
So you've asked two separate questions and I'll try to answer both of them. So if we're doing it already, why bother? Because we can do it much better. So one of the main benefits of the European Union is the possibility to act at scale. And this is particularly the case for the smaller member states. So, why did a member state like Malta become part of the procurement process for PPE or indeed for COVID vaccines? Because otherwise they're so far down the list in terms of global supply that their population is going to receive those things much later. So why bother? Because the European Union acting together can do things at scale, which gives it a disproportionate global power. What's the downside? One of the downsides potentially is to do with the balance of power within the European Union and where the health policy would go in terms of a European settlement. So a country can decide that they don't want to be part of the benefits of scale, but then they also, and then they get the freedom to determine their own health policy. But then that country also then has to take the consequences of not being part of the relevant scale. So take a country close to my heart, the United Kingdom has decided not to take the benefits of European integration and acting at European scale, and particularly for parts of the United Kingdom, and Northern Ireland is the worst affected. That means that that we have to suffer the consequences of being a smaller market. And recently, in some interviews that I was doing with health policy people here in Northern Ireland, somebody told me that a small company that supplies a particular medical device has indicated that it's not worth them supplying the Northern Irish market because the regulatory red tape to get through to that market, it's not worth it. So that's the downside. If we don't do this as the European Union, we don't get the benefits of acting at scale. And there's also an outward facing benefit, which is to do with articulating on the global stage the European way of doing health policy. And that is, and we've definitely seen this with COVID, but we saw it before as well. That is different from the Chinese way of doing health policy, from the South American way of doing health policy, and from the American way of doing health policy. So we get to articulate our European way. And we've had a very good comment in the comments. It's another example I could have used. So when you have a population of rare disease sufferers that's tiny at the scale of a member state, if you scale up to the European Union, then you can have all sorts of sensible investments in research and care and treatment for that population of rare parents. So thank you for that point, Danielle.
Well, yes, indeed. Thank you for that point. And thank you, Tammy. And speaking of investments and the benefits for smaller countries, let's move on to the next speaker, Marianne Larsson of the HealthTecn Nordic. Surely, Marianne, you would agree that there's a huge potential to actually scale this to a better level, and for both the innovation and the creation of better solutions for, well, Swedes, but for all Europeans. There's a massive potential here in cross-border collaboration. I'm not trying to put words in your mouth, but do let us know how do you see the sort of the evolution of a future towards a future health, with or without the European Health Union as a framework?
Well, I'm so impressed by listening to Tammy. Tammy knows a lot of things that I don't. I know the innovation side and the digitization side of things. I work with 250 Nordic solutions, out of which 70% are already proven and available on the market, but pretty scattered. So as Tammy says, what we do very locally and with local rules, et cetera, particularly in Sweden, we do that because the Nordic countries are pretty similar, but in one way they differ. In Sweden, we have decentralized practically all decisions to county and municipality level, which means that we're even more scattered when it comes to making decisions on a larger scale. And I would say that digitalization, health tech, please look at HealthTecnNordic.com and find 250 state-of-the-art companies from the Nordics. Those solutions could be applied together with other solutions if we had the same standards, for instance, or the same regulatory map to work in. And even globally, that would be the case. We're seeing trends. I would say that this is a transformation that we will make for democratization of health, making health accessible and affordable to all. And that could be transferred throughout the world to middle income, low income countries where they have mobile technology. Once that they have food and shelter and water, they have mobile phones. So this technology scales and is cheap, and the knowledge used to provide health solutions, health tech solutions can be spread. Best knowledge, best data, best available knowledge real time across the globe. Now, Europe would be a perfect arena to start, but we need to have the same standards and regulations to make it efficient. But it's similar to, you know, the transformation we went through with the railroads. I mean, we need to have rails that are of the same size, and we need to define the measures of the wheels to run on the rails. And now we don't have that in healthcare yet, but we could have had real-time data and knowledge and communication at scale. We could have had that during COVID-19. We didn't, but we certainly took steps ahead, making doctors' visits accessible online, etc. But in Sweden, we've introduced in local places widely, we've introduced and adopted artificial intelligence for the surveillance of chronics, for instance. Chronics being given tools, personal tools designed for them to take better care of themselves with chronic disease, and decision support tools for specialist clinics or primary care units to surveillance thousands and thousands of people. And this has proven to reduce the need for hospitalization by 50%. Now, that could be widely adopted if the standards of communication were the same, if the regulations were the same. So technology is a fantastic enabler for democratization, access for all, equality, real-time data, speed to response to threats, etc. It's such an enabler, but we need what Tammy is talking about. At scale, the same regulations, not scattered decision-making. Now, decentralization is marvelous for many decisions, but not for railroads.
There's actually a question already here. How do we make sure we are not making a gap in healthcare between the digital literate and the citizens with a lower digital health literacy? And especially, of course, a lot of your members in HealthTecn Nordic, they're busy churning out solutions. But of course, there is an obvious challenge in well, a market fit would, of course, appeal to those where you have the strongest potential. And the strongest potential would often be with the digital literate. How to balance that?
I would say that's prejudice, because the studies that we see now are made on people at the age of 90 or 100 and 104, and they love the equipment they get. Because if you design things for them to use, that's why I said personally designed equipment. That would differ if you're 15 or if you're 94, or if you're tech savvy or not. There's opportunity for the design for different people with different needs. And that's what's being done. And the results are tremendous, surprisingly good. These people in cases where it's just a study, and people have to give back the things that they've used, they feel they've been feeling a lot safer. And when they give it back, that's really unethical to do. It should be, you know, if it's proven and it's good and it works for the person, it's unethical to take it away. So I would say it's prejudiced, but there will still be people that don't have the right solutions to participate. And I suggest that we maintain all the analog and physical events and opportunities at the same time, but at large, most people will have designs that are affordable and accessible and useful for them. So let's not stop because of that.
Or maybe
make it happen.
You're indirectly suggesting that that this perhaps is more of a myth, in the sense that better design would solve some of that problem, and it's creative designers and developers will find solutions that fit that.
And I would in my experience, what I see is when the wrong people start developing, I'm not saying, I'm saying the traditional structure, when traditional healthcare providers start developing themselves, they're often 5 years behind the development on the market. And the market lives on having people using their things. And they've learned so much by then about everything, about the solution and the service or the technology or the user interface or whatever. And they need to be very good at that. But when we start inventing the wheel again with people that are not design thinking or not good at developing technology, those solutions don't work. And when we have systems like in Sweden, we have the bank ID, we can use it with to acknowledge that I'm me. That is used frequently for health services now, digital online services in Sweden. I know I can transfer bank money to you in Denmark on your mobile number with bank ID, but other countries don't have the same solution. So immediately comes up problems where we need to have the same standards for communication to be able to communicate, like for railroads. So that's where we need to raise the level of decision. Yeah.
And I can also attest to the fact that even though, for instance, I have a house in Sweden, I don't have a bank ID since I'm not a Swede, and that can create all kinds of other problems. So but moving onwards, perhaps to that element, and the element, I guess, about interoperability as well and cross-border collaboration, we turn to our next speaker, Bogi Eliasen of the Copenhagen Institute for Future Studies. You've certainly been a strong voice in talking about, well, getting ready, being ready, looking at the future. Is then this is this a paradise perspective we are talking about, or is it perhaps a garden of roses but also full of thorns? The future of health in Europe, with or without the European Health Union. Your thoughts?
Yes. So is it a garden of roses? Probably, but we need several gardens and not just roses, and there will be thorns in the roses as well. So yeah, I think the readiness to look forward is something that we underestimate, and this makes it very hard to actually apply what we already have, which we have heard from the two previous speakers as well, because we are only beginning to fertilize the ground to use technology and concepts once they are almost there, and that's very late in order to have both the societal readiness, which means understanding from the general public, from the systems around it, but also with the other technology and concepts they need to play with. So both a technological and non-technological interoperability, so to say, in that way. So I will take this a little bit further and say, why would we need a European approach, which I fully agree on, which you've heard before, but this is also a human approach. It's health as a human right, but it's also health as a premise for development of societies. And we need to think big scale. It's not just for rare diseases. If we want to go on the road of personalized health, which I think we should do in order to be better at this part, most disease areas will have elements that are like rare diseases that you would need big populations in order to have the best possible understandings and to work on it. So in that part, health needs to have persons first and jurisdictions next, and Europe can actually develop that. It's harder in other places. Then it comes on, what is it we should focus on? One thing is to deal with the challenge that is present. Another thing is to focus on other things of the challenge that we actually could avoid. So the avoidable disease burden, which comes into different kinds of preventions. While we for thousands of years have known that we should prevent, it's not really applied and it's not reimbursed. So there are some things on what is it we want to pay for. We really need some examples of agreed on, understandable and supported business cases on not just the prevention, but also early detection and early intervention in these parts. And that requires a lot of stakeholders coming together and working. And in the Nordic Health 2030 that we worked with, one of the concepts we developed together was to say, let's by 2030 have an approach where we use half of the resources on prevention, but prevention on all scales. So not just primary, also the secondary and tertiary. So working also with people in preventative measures or preventative ways in a treatment situation. Having in mind that behavior is not just important to keep people healthy when they are not ill, it's also very important to optimize the outcome of treatments while in a chronic or non-chronic disease situation. So I think that is very important in it. And it's very what we can do in a European setting also, and having, for instance, the Horizon Europe, IHI, and the permit structure that can have scale, have a lot of stakeholders and look years ahead, is to develop cornerstones on what is the playing field we want to have in health. Most of the energy goes into dealing with challenges with new technology because we didn't think how we want to have this in society. So that's another part that I see great use for. What do we want for the European citizen or the global citizen? There's clearly need for a new paradigm in health. We have a treatment regime, we don't have a health regime. So I would hope that the European Health Union could be a health regime. It's about quality of life and well-being during the lifespan. Most of us will have diseases for longer or shorter periods in our life, and disease will be a part of health systems. But keeping people healthy, or as healthy as possible, should also be a part of it. And then we have huge challenges also in Europe with that our risk sharing models are not good enough. The access is not good enough for everybody. So how can we work at scale to have broader risk sharing mechanisms? So if health becomes cross-jurisdictional, we very likely also would need to work with risk sharing models that go across jurisdictions in some way. And we have already established concepts like social determinants of health that we can use, leaving no one behind, which is being pushed very much, health and all policies, which should have been much more on the country's agenda, and of course the social development goals for 2030. So thinking here is what provides health, not just how do we deal with disease when it's present. We also need to do that, But what provides health will actually give us more room to work with the disease when it's present. So that's the priority we need to get into place. And that needs large-scale thinking, needs cross-border thinking, and it actually needs a new health paradigm that needs to help us to get towards that part. So one thing Marianne mentioned on the possibility, we should have possibility to work with real-time data. Yes, technology is there. But what is it we want to think about? So if we want personalized health, we would need to have linkage data, not anonymized, huge anonymized data repositories, which are fine for some research, but not really that good if we want to be treated. Nobody wants to be an anonymized patient. What if we turn the question around, instead of thinking about big repositories for biobanks and data, and say, and with federated data system, we begin to think the person as its own data repository and biobank, because we would need not just to be linked to clinical data, but actually to behavioral data, micro and macro environmental data, and probably societal data that are accessible in the country where you live, but it needs to come into the hands of the individual. So what is missing here is to think about what is it that the system needs and can help the health for the individuals, and what is that the individual needs to have access to in order to be able to live in the best possible way, both when healthy, but also when they're ill. Thank you.
Thank you, Bogi. There's all kinds of elements here that springs to mind. You mentioned these health and all policies and so on, and daring to take a small stab at the current youth. Sometimes you can have the idea that they're sort of our generation's version of memes, something that's really good at sharing, but doesn't actually mean much in essence. But can look really cool in a post or in a share, and got a lot of likes. But are they more than that? I mean, is it when you develop things for the future, of course, even though today we're talking about the European Health Union, often they don't happen overnight. Is it sort of just the proto policy development element that we're witnessing, the soup of good ideas, whereupon we're actually able to finally extract a wonderful dish of future health?
To a large extent, yes, sadly. Marianne's example with the size of the track is one part of this. And what we do a lot, or are trying to do, is to look 10, 15, 20 years ahead and then backcast in order to have a consensus on where is it we want to go, because then it becomes much easier to talk with people about how to get the same tracks. So the mutual benefit on it. So let's go back to the core points that we are trying to push forward. One of the things that we hear a lot is that climate change are the biggest challenges for the future of health. It's the other way around. If we don't get health right, if we can't provide basic, good enough health, not just to Europeans, globally, there is no bandwidth to work with climate changes. Okay, it's a fundamental thing in order to get societies to work. We need a new social contract. We need a new digital social contract, which is not just your local environment or your country, not just jurisdictional. Health is a part of that. Bandwidth to work and go forward requires health. It requires a risk-sharing model where you are not in the risk of bankruptcy because somebody in your family gets ill. So it's a fundamental human right. So I think the question, in order to be able to work with an agreement on some of these polarities that we have it has to be seen partly as a human right and also as an investment for stable societies, where health today mainly is seen as a cost. And where health and health policy comes in is, I mean, when you do legal frames in most countries, you need to tick off what is the environmental consequence, etc., etc. It should have what is the health consequence of this, having in mind that most health progress did not come from the hospitals. Clean water, education, better work conditions, refrigerators, food security. We need to get that mindset in also to the future of health.
Well, I asked you to talk about cross-border health, and you certainly did, Bogi, in so many ways. Let's invite Marianne and Tammy back also. There's an immediate question that I think that would be relevant to ask all three of you, which was actually the role of patient organizations in the future. Let's take that question first, because obviously citizens and incidentally, I don't think that's the right word, but patients sometimes are a key element here. But what's the role? Are they canaries in the coal mine, perhaps, or are they the social movements that is actually pillars to build upon? What's the role of these organizations? What do you think?
Shall I begin and then
yes, Tammy
can add? Thank you so much. So patient organizations to me are a really critical stakeholder in terms of developing robust health law and policy. So just as in the disability rights movement, nothing for us without us. So that's my very simple answer to the role of patient organizations. And from my point of view, as the European Health Union develops, it's very important for the democratic legitimacy of that European Health Union that patient organizations as a very important stakeholder are given an institutional place in that European Health Union. I don't want to overstate the neutrality of patient organizations, and others on this call will also be aware that there is a whole phenomenon of patient organizations potentially being captured by big pharma, for instance. So we mustn't be naive and think about patient organizations as an unqualified good, but to me they are an extremely important health stakeholder whose voices need to be heard. Nothing for us without us.
Indeed. Marianne, you had a comment too?
I totally agree, and I'm just curious when that will happen, because governments and authorities have had that opportunity for years and years and years, and now the healthcare system is really difficult with an aging population, growing chronic diseases. 80% of the healthcare cost goes to chronics, and if we could prevent a lot of that, or prevent the emergency, the development of each individual's chronic disease, etc., we could do a lot. But no one, or very, very rarely, we talk to patient organizations. So why not? What is the hurdle?
Yes.
Bogi?
So yeah, so this is where the futurist comes in. Yesterday, I actually was moderating a meeting in Latin America between some of the major patient organizations and the networks of patient organizations, where we have, so it's an initiative taken from the Institute, where we have set up based on communication with patient organizations all over the world on how can we go forward. So what is the responsibility patients organization take to develop the new health paradigm? Coming back to Tammy's point on, yes, it's not the day-to-day. I have full understanding for patients organizations struggle to secure access here and now for their patients. And this is not about leaving that, but it's adding a responsibility to what is the future role. So our idea, what we have pushed forward is how do we secure, what can enable better collaboration between patient organizations, because they are in a bit of a wild west in most of the world where they need to compete very hardly, and it's not the common good and not their own best interest that goes forward. And what we have pushed here is saying, okay, everybody agrees on prevention. We have talked about primary prevention for 5,000 years. If you take the Chinese inspiration, it's not really in focus. So what if we go hardly into secondary prevention? We go in and focus on the data picture of the secondary prevention. The patient organizations can help with the patients, because patients are often hardly hit and you cannot ask too much often. And we get that bridge between the clinical world and the non-clinical world for the best outcomes for the patients. So that's the idea we are pushing now in Latin America as a test case. And if it works, that's something we want to push globally.
An important point you raised there, Bogi, the Wild West of patient organizations. A recent debate in the European community has been the decision by the Commission of not really funding these NGOs going forward as part of the EU for Health. But I mean, some of patient organizations, or you might say a lot of them, are actually struggling to breathe, struggling to survive. Elements on how to improve the ecosystem of these vital organizations. How can we improve their sustainability, I suppose?
Yeah, but I think going back to both what Tammy and Marianne said, they have, I mean, of course, patients are an integrated part of this. I do. If I put the responsibility, a part of the responsibility to the patients' organization is that they together would need to define what is their role. I work not a lot, but a fair amount with patient organization, and I have the deepest respect for all the things that are being done. It is very good, but the next challenge we have is not just for patients organization, it's for the whole ecosystem to realize that it's a new paradigm, and the patients organization have a part and a responsibility, like all of us do have, in defining that paradigm, which then could lift us to more cooperation. I do not see that happening in the current mindset.
All right, but and with that, let's move on to another stakeholder group that can sometimes be a little bit challenged in the current healthcare setup, the healthcare professionals. Well, when we've talked about the railroad tracks, the comment that we had in the chat earlier was about the recognition of healthcare professionals across systems, and that system of recognition is very fragmented. It makes it, and we've talked about, of course, for years and years about the freedom of movement, the freedom of that to be able to work in other countries. But for healthcare workers and for, I suppose, the agility of our healthcare system, that has had some huge challenges, both in recognizing the different competencies of the healthcare professionals, even the educations of them, and so on. How also, I mean, we've talked with the doctors. I guess that's been the most focus, but certainly also for the nurses as well, about the element of burnout. I know in many countries there's the element, of course, of recruiting enough, and people are leaving. In various countries also the profession in droves. So if talking about all the things that we've talked about so far, what if we don't have the people to staff this wonderful system? What are the challenges there, or for that matter, the roads forward? More pay, simply?
Can I give an example?
Yes, please.
So I've had a task for one of the Danish regions. So most in our part of the world, when we have general elections, the health part is mostly about the lack of nurses. I think it's a very cheap and not very fair point from the politicians, because there are no more nurses. So it's irresponsible to keep on taking that. So the question here was saying, given that these are the nurses we have, what can we do? And given that we have a lot of data in Denmark and the Nordics. How can we look at patterns so we can resolve some of the issues before they require help from nurses? So I think it's turning the things around and say, where do we provide most value in the chain in order to solve the challenges that we have? And that's not necessarily to employ more nurses, especially when they are not at hand. So I think that's where we need to redefine it. And we also need to, if we want to take some of these marvelous things that that Marianne has in our HealthTech hub, everything is not going to happen in the clinical setting. So how do we get that in?
Yeah, Marianne?
If we don't have the nurses that we have or the doctors that we have, that's very tragical, because they will all be needed. And I would suggest, I can see from those that are engaged in using new technology that their experience is very positive. It may be about salaries as well, but also about how their work situation is. And now the example I gave about chronics, if we can put better tools in the hands of the chronics and better tools in the hands of profession, and they can surveillance thousands and thousands of patients and act on those that need them when they need them, instead of receiving them every 6 months for 15 minutes, whether they need it or not. That's how they spend their time today. I think most healthcare professionals have trained to help people. If they can help, if we say like we reduce the need for hospitalization by 50% by introducing these new technologies, and the healthcare profession can take care of more people when they need it, that we will need every nurse, every doctor to take care of the increasing amount of people in need of access to care. And secondary prevention, as Bogi mentioned, is so highly important, and that can be done. So I don't know how to solve if they leave, but I'm quite positive towards that they will have a better working situation if we adopt these new tools.
But also maybe in this case, asking you, I suppose, Tammy, this is one of the key elements where you show the value of having the European Health Union in not having sort of a treatment perspective on this issue, or not having a national perspective on this, but recognizing the ecosystem of a joint challenge. So maybe to point Bogi's, the cheap point is because they can, or they're trying to steal nurses from other countries have been an approach for a number of years. And unless we see it as a joint ecosystem, well, to begin with, across Europe at least, we will fail to also solve some of those issues. Is that, I mean, is that also one of the key elements for the European Health Union?
Thank you. I also want to respond to one of the comments in the chat about this point. So the migration of health professionals is extremely complex, not just within the European Union, but also globally. And there's a very simple narrative that goes, you know, health professionals move from poor countries to wealthier countries. But that's, you know, the data shows that it's much more complicated than that. It isn't the case that there's just a brain drain of health professionals from the global south to the global north, or from Eastern Europe to Western Europe or Northern Europe. It just isn't quite as simple as that. So one of the points that's really important here is which is a point that's been made already by the conversation so far, is that we need to share data on this so we can understand what's happening, so that we can then make an effective policy decision. So that's really important. On the comment in the chat, in terms of automatic recognition or recognition of other qualifications done in another state, actually the European Union has done way more than any other international entity to try to achieve this. Part of the reason that the European Union could do this is because it based its approach on a common European institution that has been present for centuries, which is the university. So the European Union was able to move quite a long way with mutual recognition of health qualifications compared to other states globally, or other global organizations that try to have automatic recognition of health qualifications. And automatic recognition isn't necessarily a solution, because a health professional qualification is a warrantor of patient safety, and it's also potentially a guarantee of against huge drain on the system if something goes wrong. You know, if you have an unqualified professional. So not just in terms of individual human life and suffering, but also systemic problems. So it's not a simple solution just to say, well, you know, we'll have some global standards and we'll just recognize those. That wouldn't be an appropriate approach. But one of the things that we learned from COVID-19 is that there's a lot more tolerance for recognizing different levels or different types of professional training and formation when it's a crisis. So we can now apply that in a much more calm way when it's not a crisis, and have some very calm and sensible discussions about, you know, what could we recognize, and so on. So that's a kind of a preliminary response to these very interesting and interconnected issues that are raised both by your question, Lars, and the comments and questions in the chat.
Well, yes, also, as you say, better data for the healthcare professionals, but also for patients and so on. Having a nationally separated system can also, I suppose, in this case, hide systemic challenges within each of the countries. Oh, we don't have enough nurses. Let's just take one from the other country and problem solved. And I real that it pushes systemic problems away instead of solving them per se. But also then, yes, Marianne, please. Your mic.
Sorry, I have some workers working on my house right now. I'm sorry if you hear that in the background, but I'll try to make it quick. I see this question about where we see the research, patient involvement, co-creation in medical research, etc. I would like to give an example of what we can do if we use data and health tech in the future. I will give the example of IBS, you know, irritable bowel syndrome. That's a diagnosis that is a black hole. We don't have any treatment. We don't know what it is. And people get that diagnosis once that they have a stomach problem, and they get all kinds of you know, interventions to see whether it's cancer or ulcer or whatever. And when everything is ruled out, they're labeled IBS. Okay, so that's a black hole diagnosis. Now, what if one of the solutions that is in HealthTecn Nordic is an app for people with that problem? If they get some support to see patterns in their diets, etc., and see whether it's a banana, 6 hours after you have your banana, you seem to have a problem, please look into that. You know, analysis that is very personal. If many people would use that, it's an increasing problem. Let's say 1 million people use that app. If we would have data from 1 million people or 4 million people or 10 million people, we would know a lot more. That's where research comes in. So we would have anonymous data, as Bogi talked about, but we will learn what is IBS. Perhaps it's 10 or 20 different diseases, and perhaps we can develop treatment for it, knowing a lot more about these people. And then that would be pushed out, treatments, suggestions to the individuals, depending on their particular disease. Now, if you convey that kind of thinking into cancer or rare diseases or whatever kind of disease, with millions of people data, we will know a lot more. We will develop very much faster, as we did in COVID, new treatments, new medications, etc. Yeah, so that's where research comes in, I think.
All right. But recognizing that we're slowly running out of time today, Bogi, you have a question. I'd like to ask each of you a question. I guess you can fit that in, Bogi. The element both, we're talking about from the perspective of Sweden today. So the one question would be, why should Swedes care what happens, what Swedes in Gotland, or perhaps the rest of Sweden, why should they care today, tomorrow, what happens with the European Health Union? And two, what steps would you really like them to see if they do care? What should they do? Bogi?
Yes. So as I said, I mean, health. If you want health to the challenge you might have, Sweden is not going to be big enough to provide the knowledge, and that comes back to Marianne's point as well. I would just like to stress here, I do find a big value in anonymized data, but we are doing double data sets, and is that feasible? Because we also need the clinical data sets with linkage data, and we have federated data systems. We have, in the end, it comes back to what Tammy also mentioned, it's safety for the patient. That has to be the main goal. And I will just ask if it's worthwhile using more effort on anonymized data sets where we actually could build one where there also is some linkage in it.
Some key advice from you, Tammy?
Why should they care?
I think Marianne made a very good point, I'd say, but maybe you have an additional point about how to get something that might be, well, small now, but can only be solved by power of the numbers. But also, of course, the other element, what should they do?
Why should they care? Because all of humanity is interconnected in terms of our health. And that's understandable to the ordinary person now in a way that it has not been for generations. So that's why they should care. What should they do now is understand and learn. And again, we have unprecedented opportunity to learn because of the internet about how interconnected we are globally in terms of health, and also how useless the nation state is in terms of solving health problems, especially a small nation state, but even large nation states. So the structure of the nation state is pretty useless when you have to face a pandemic, but it's also pretty useless when you have to think about chronic health problems for the reasons that we've talked about, or in the whole of this extremely rich session. So that's why they should care, and that's what they should do.
A very poignant way of putting it, Tammy. Yes. And allowing me to both thank you all for inviting us to Sweden, virtually anyway. Marianne, I'll give the final word to you. What would you suggest you Swedes should do in the coming days?
Okay, so Swedes, we have oh, sorry. I'm here. Yeah. So in the coming days, I think as individuals, as citizens, if we have a problem, we should try to look up, is there anything online that I can use? So start pushing from the patient side. For instance, if I have a problem with my arthritis, there's Joint Academy. It's accessible. It's proven. It has better results than the traditional physiotherapy. You get a physiotherapist, etc. If you have mental health issues, look on the line, is there anything? And start driving from the patient side, and dare using it. Try it. I mean, it won't bite. It won't bite. These things that are available are proven and have good results. So yeah, so try things out. That's one thing to do.
First and foremost, do act and care, I suppose. Thank you all for joining this session today. And as a reference to the rest of you, we'll make sure to put the recording online as soon as possible, and to keep the conversation alive about the European Health Union. We'll be, of course, trying to dive into the same topic again in Norway and Finland in the immediate future. But thank you very much for joining. And thank you very much, speakers, for contributing your insights and expertise on this issue. Thank you.
Thank you.
Thank you.
Lovely.
Thank you so much. Bye.